All right. Good morning, everyone. Welcome from Mount Sinai Hospital, New York City. Today, January 27th, 2016, at 8:05 p.m., 8:05 a.m. Eastern Standard Time. We welcome you for another session of Peripheral Interventions. First of all, I, Vishal Kapoor, would love to wish you a very happy New Year from our team. Hope you had a very enjoyable New Year and it's going great. Today, we're going to start with another exciting case with Dr. Krishnan leading the case, saphenofemoral lesion. Before we go on to the case, let me send you that you can see our case live at the end of the week, which is archived at peripheраlinterventions.org. If you have any questions or comments regarding this live case, you can also email us at info@peripheраlinterventions.org. Or the easier way is on the website. There is a link called Ask Me a Question on the right-hand corner. Just click on it, and we'll be more than happy to answer any questions. So I'll let Dr. Krishnan take over and go ahead with the case. Morning, Dr. Krishnan.
Hi, good morning, Vishal. How are you? I welcome you and everyone here. We had a very exciting week so far. Dr. Kapoor, myself, and Dr. Guja were honored to present two cases to Link yesterday. And so those cases went really well. And building on that theme of really complex SFAs that we did, we want to present a case to you today. Is Dr. Sachin Jain over there?
Yes, I'm here, PK.
Go ahead, Sachin. Why don't you give the introduction to us?
Yeah, sure. Good morning, everybody. Welcome to the Interventions live case today. We have a very interesting case today. The patient is 66-year-old woman presenting currently with the right lower extremity claudication with one block. Rutherford grade 2, category 3, Fontaine 2B. The Wi-Fi classification is no wound. There is a significant ischemia and no foot infection. Patient had a CLI on the left leg, and as you see, she had a non-healing ulcer on the left foot with osteomyelitis of the first metatarsal and lateral hallux, and she underwent left SFA PTA stenting in December, followed by infrapop intervention 2 weeks ago. Patient significant medical history includes hypertension, insulin-dependent diabetes mellitus, CAD, and dyslipidemia. Currently, she takes aspirin, Plavix, Lopressor, insulin, Januvia, Crestor, antibiotics for her infection, and Neurontin. Prior to this, the ABI on the right lower extremity was 0.6, which is the leg of the concern today, and then left side was 0.2 prior to all those interventions. The plan for today is doing angioplasty of the long chronic total occlusion of the right SFA. Back to you, PK.
So we're having some problems with our DSA being transmitted. So what I'm going to do is have them shoot from within the room, which I think is going to help all of us. So this is a picture of the other leg that we had taken care of. So what I want to show you is what happened to us when we went up and over with the wire. So immediately what happened was the 035 wire, this looked like an ostially occluded SFA in our diagnostic shot that we took. The 035 wire basically slid all the way down to this point. So I think the important teaching point that Dr. Kapoor will echo in a few minutes is that when you see things like this, you have to think about thrombus. So you know, yes, you have a very calcified lesion in a diabetic who's a claudicant with an ABI 0.6 and 0.2 on the other side with an ulcer. But I think more and more as we're starting to do these lesions complexity-wise, we're realizing that thrombus plays an incredible role in these long lesions, especially long occlusive disease. So if you go to the next one, again, I want you to come off from inside, and maybe you can shrink my picture. Thank you. You'll see here that this is just a regular injection. Pardon me. We'll go here. So you'll see here that the wire has really created a channel now. So that channel shows, and you can see by the filling characteristics, there seems to be some sort of thrombus or maybe some sort of filling defect, I'm so sorry, with the occlusion of this particular vessel. Okay. So then if you go forward to the runoff, you will see then that the popliteal is open. Here's the distal SFA. And again, you'll see delayed filling of different areas of the SFA, suggesting that you have occlusive, subtotal occlusions with areas of hibernation, with areas of total occlusion, suggesting that thrombus is going to play a role within your intervention. Now you can see with runoff, she has single vessel runoff. So when I want all of you at home, when you see this, is to immediately understand that you're going to be dealing with thrombus when you're dealing with this type of case. So to further illustrate, Ray Lascano and myself went ahead and put a catheter into the SFA. And you can see the catheter is moving smoothly till we hit a calcific patch there. Then we went with a glide wire just to get the catheter a little bit further to the area of where it really stopped. And then we injected. So now when we inject, I want you to see, do you see the filling defect there? Do you see how there's filling defect? It's really, you have a little AV fistula. It's because I'm injecting right into a collateral. It's not a big deal. But you see that you have a little bit of filling defect, a little bit of thrombus or whatever. So at this stage, we decided now to go ahead with our 014 wire to illustrate how this is going to cross. And you're going to be very, very surprised how this is going to cross. Now, normally, as you guys know, we don't do anything other than 035 wires here. Generally, for SFAs, we don't believe in this fancy 014 stuff. But you can see here, okay, that looks a little subintimal. I don't necessarily like that. Let's see here. Okay, same problem there. Let's see. Okay, there's a little bit of a calcium. But look how smooth this thing is moving. It's amazing to me how smooth. Look at this wire. Look at how this wire moves here. It's moving that way because it's not totally occluded. It's got areas of occlusion with areas of stenosis. You know, and I got to tell you, you know, I didn't introduce my team, and I apologize for that. See, now we're across the lesion. See that? Show me down, guys. See that? Now this is what I want to demonstrate because this is incredibly important. Because, you know, you're not that good. Nobody's that good. It's not that, oh, my God, you know, I'm through and, you know, I'm showing off how good I am. That's not at all this. And you can see here we're still subintimal in certain areas. But I didn't introduce my team. Let me introduce my team. As you know, we always work here with Ray. We're missing Dr. Kapoor at this level because we're a little short-staffed today because Dr. Guja had family issues. And Elizabeth, our nurse, and Ricardo, our tech, as always, is here to support us, as well as our wonderful audiovisual media team. So I really am grateful for all that. So as you can see now, we're just crossing this lesion with a little bit of difficulty and much better there. But again, you remember, you're going to go intimal and subintimal. But again, it tells you that you have a lot of thrombus here that you're dealing with and a lot of other types of tissue or other things that you're dealing with here. Let's do a little roadmap here, Ray.
So let me ask you this, Dr. Krishnan. If it wasn't for the 035 wire passing, what other features do you look for to really see it's a thrombus versus a chronically severely calcified SFA? Will you still start with an 014 or you'll directly go with an 035?
Well, generally speaking, we'd go with an 035, and we may still have to go with an 035 here. I just feel that the way this is moving, you know, in certain areas, it seems like it's total and subtotal.
Right.
So the other thing we could do is kind of advance the catheter and then try to see where this is going, you know, and then see how it works. You can see it's within that calcific shadow, but there it seems a little subintimal. Now remember, I have not advanced the catheter. Even if I created a small dissection plane, it's an 014 dissection plane. It's not an 035 dissection plane. So I'm okay with all that, you know. So, you know, let's see. I mean, let's play with this for a few minutes before we convert. You know, I may be wrong, but I think the point here is really to talk about thrombus management in these kind of cases. Angiographically, clearly that definitely looked like there was a lot of other things other than what is it called, atherosclerotic debris in there. It clearly looked like you definitely had some thrombotic debris, and you can see how this catheter just kind of flows freely through that, you know. And let's see here. There it's not. I'm going to try to torque it on this end here, try to direct it to another spot. The other thing you could do, and I've seen this done, is very simply just go with a fine cross and just push it down and see how far it goes. So I'm trying to avoid that plane again by going more lateral, like in that manner, but I'm still getting into that one area. There we go. Let's try over here. See this, Vishal?
Yes.
This clearly is moving very nicely.
Very smoothly. And
see that? Look, let's see this. See, now the wire is a little bit more restricted, but in this area it clearly is not in a subintimal space. So I'm just going to try to advance this a little bit. Now, a lot of people will say, well, hell, it doesn't make a difference. You're going to stent it anyway. My perspective here is, rather than say I'm going to stent it anyway, I think we've realized now, as Sachin is going to talk about long lesions, on how to deal with these lesions in a different way in today's era and with all this data that we have available. The other thing we could also do is to try a dedicated crossing catheter like a Viance and see whether that's going to help us get this down as well in a more smoother manner. So that may be something we might be able to try as well. See, right there, it seems to be doing some crazy things.
Right. It just
So I
deviates
think
off the
that's
path.
that's the occlusive part right here. You know,
There.
that sounds a lot better now. Ray, give me a little DSA here. I mean, or just a picture. Ready, regular picture, inject. So you can see that you're well within the calcium, and you're heading in the right direction. So I kind of like this one a little bit better. Let's see how this one heads. Certainly a hell of a lot better. Right here, a little
Right
bit of
here.
problem. Need a little bit of patience here. You know, as far as opening up devices and things like that, I think that, you know, there's really, most of the time, there's no reason. You know, and I think in the SFA, these crossing devices should really be a last-minute bailout kind of thing. I'm going to ask for an 018 Trailblazer here, guys.
What wire are you using right now?
I'm just using what is it called, Confianza. No, actually, this is a, what is that, a 300, what is that wire? The Win 300. The Win 300. So I think right now, Vishal, I think this case is, of course, about recognizing things like this, but it's also about recognizing, you know, what the data says right now in crossing these, once you cross these kind of lesions. So once I cross this, I really want Dr. Jain, our fellow, to go ahead and go over some of the latest data with drug-coated technology as well as other technologies in long lesions, sort of like an update on to our audience, because you know the data is always evolving. As you know very well, DCB long lesion data has been presented and not published yet, but it clearly has been presented. So with the impact long lesion data from their global registry. The second thing is Lutonix long lesion data has also been presented, okay, by Dirk at I don't know which conference, but I know he presented it. So the issue just becomes is that, you know, we have a lot of other information now that we can use to treat these patients. So in the past, we were kind of left with, you know, atherectomy and ballooning and stenting, and that may or may not be enough, you know, for these type of lesions. We know that, you know, in the intermediate term, these patients did quite well, but in the long term, meaning greater than a year, these patients did not do well at all. So while what I'm doing, so I think that this is an interesting time to bring up a case like this to really see what we can do to do this. Hold on a second. The other thing I want all of you to understand is, as long as you haven't really used an 035 wire, you might be able to inject through the catheter to find a microchannel. Now, generally speaking, I don't like doing this, especially if we're subintimal. But here, I'm not certain we're subintimal, so I'm just going to give a little bit of dye. Give me a roadmap, actually, yeah, just a roadmap, just to see where we are, and then we decide. So you see how much vessel is patent?
Yeah.
So this is what I'm trying to say. When you take the angiogram, you're not seeing that kind of vessel that's patent. So therefore, it's very important for you to understand that you need to understand how the vessel reacts to your wire and your catheter as you go down. So now I know I'm in the vessel. I know I'm in a hibernating segment of the vessel. Now I'm going to try to go ahead and advance this into the occlusion and try to stay intraluminally. Now, there's a lot of questions about intraluminal versus extraluminal cross, and as you know very well, there's really not enough data to support one or the other.
Right.
But I think at this stage, you know, why not? If we can stay intraluminally, why not stay intraluminally and see what we can do? But again, we're having a lot of trouble with the distal cap. So Vishal, what are your thoughts on cases like this, when you do cases like this?
No, I mean, essentially, what I do is usually try to be, I mean, you begin with an 035. I usually like to begin with an 014 to get a feel of how the lesion is responding. Like you said, if there's chronic thrombogenic material in the vessel, then 014 hopefully should pass with just minimal you know, complexity. However, if we hit a CTO or a calcified stuff, then I usually switch over to an 035 system to give it a little bit more pushability and strength down. So, I mean, in your case, it worked perfectly fine because the initial part looks more chronic thrombogenic, and the distal there is a cap as well. So it's probably just adding on to the complexity.
Yeah, right here, there clearly is that this cap is being a pain in the neck, but it seems like our 014 wire did the trick there, as you can see by the movement of the wire. So, you know, this is a great case to really talk about this. So let me tell you what we're planning on doing here. I'm planning on tracking this this catheter down, and then I'm gonna put a 035 catheter down, and then I'm probably going to end up doing a thrombectomy here, followed by with the filter protection if need be. So I'm going to go ahead. Give me a Spartacore wire here, guys. Actually, give me give me a bare wire and an Abbott filter. So we're going to use a bare wire here because we've got our catheter down there. And then what we're going to do is we're going to use a 4/7 Abbott filter, and then we're going to go do a reolytic thrombectomy, followed by then we'll come back live to you. In the meantime, let Sachin go ahead and present the case. I'll present the data that we have prepared.
All right.
Thanks, PK. Good morning, everybody. Again, I'm Sachin Jain, endovascular fellow. I'm going to give a update on long SFA lesions, the treatment strategies. This is not a complete list of all the studies, but at least update on the newer technologies. So what do we mean by long lesions? Most of the studies have enrolled patient either type A or type B lesions, but here we are talking about high-end type B, type C and type D lesions, which are chronically occluded or long stenosis, and we really don't have a data of these type of long lesions. So this is a summary of studies of SF endovascular therapies. These are not head-to-head trials. These are individual trials, just talking about the primary patencies of individual studies for the individual therapies. So we cannot compare the trials because the patient population is different. As you see down, even the way the primary patencies are evaluated is different. But it at least gives us an idea that for example, here is the total number of patients in the top column. This is the length of the lesion in the middle column, and this is how they detected the primary patencies. In the first, if you see in the supera, the longest lesion or maybe is 12.6 centimeter in the supera 500 with a close to a 1-year patency of 83%. Going to Zilver, which is a drug-eluting stent, is close to 83%, but again the longest lesion is mean length is 10 centimeters. Going to other type of bare metal stents, again the longest lesion is in the Stella and durability stent, but again with the low patency rates. Going to covered stent Viabahn, they included very long lesions in the Viastar and Viabahn 25 centimeter studies, giving a patency close to 70%. Going to the different atherectomy devices, again as you see, other than the definitive LE, most of the lesion lengths are smaller, and in definitive LE is up to 65% 1 year just using a directional atherectomy alone. And more and more data is available on DCBs now. This is just from the Lutonix Levin 2 studies. Lesion length is again only 6.3 centimeter mean length, and with a 74% primary patency. And as we know, PTA fails. It's only 33% compilation of multiple studies with the mean lesion length of 8.7. Just want to talk about this slide. This just compares the different stent technologies, and as you see, across different patient population, but the average length is all less than 10 centimeters, and seems to be the newer nitinol stent technology with the supera and then the drug-eluting stent do better than other stents. And this graph is across the different lesion length, and in the x-axis with the primary patency on the y-axis, as you see, as the lesion length increases, most of the therapy fails. Seems like supera may be keeping up, but again the lesion length close to 10 to 14 centimeters. So what do we have update? So I want to go over the newer the supera stents data, the drug-eluting stent data, and the DCB data. So super clinical trial, as we know, the average length in this patient is 7.8 centimeter with a primary patency from Kaplan-Meier curve is close to 86%. But a subgroup of that patient, which they divided into short lesion, middle lesion, and the longest lesion being 12 centimeters plus or minus with 87 patients, it stayed close to 87% as long as the stent is deployed at a nominal fashion. Supera 500, it's a German single center registry, including 470 patients with 749 supera being implanted. And you can see again for primary patency of 83% with the secondary patency of 98%, and the average lesion length here is 12.6 centimeter. And again this is the graph where they have divided the lesion, and the long lesion with 172 patients, there is 81% primary patencies, and the patency remains significantly good. This is the data that is presented in Viva. It is not peer reviewed and not published. It is a Cook-Silver PTX post-market study in Japan. The paclitaxel coated silver stent, single arm, done in Japan, multi-center prospective post-market surveillance study, which included 907 patients. They evaluated the TLR, which is defined as reintervention performed for more than 50% diameter stenosis if there is a change in clinical symptoms, and the benefit being not worsening of symptoms of ischemia, and patency was evaluated with the ultrasound. And again in these patients of 907 with 1075 lesions across 95 institutions in Japan, the mean lesion length is close to 15 centimeters, and they also had a more complex lesions in the subset. Follow up for 24 months, patency rate of 72% in the Silver PTX study, and this is a registry from Japan. What do we have on drug coated balloons? We have two balloons currently available, the IMPACT SFA trial followed by the global study. In the IMPACT SFA trial, and you see there is a 80% primary patency through 2 years in the regular study, but if you look at the subset in the lesion length of 10 centimeter to 18 centimeter, there were 79 patients, and there is 72% primary patency in the drug coated balloon. And then in the IMPACT global study, they enrolled more than 1500 patients, and they had 3 subsets which included for ISR and a long lesion and also a CTO cohort. And in the long lesion they included 157 subjects. So this is across the study of 3 studies, which is IMPACT SFA, comparing to the imaging cohort of the long lesion and also ISR. Here the mean lesion length is 26.4 centimeters, and it did very good with a 91% primary patency based on the Kaplan-Meier curve at 12 months, and in ISR group it is 88.7%. They have further also divided the lesion based on the long lesions from 15 to 25 centimeters and more than 25 centimeters. In 15 to 25 centimeter lesion, the 1 year patency is close to 97%, it is very good, and then more than 25 centimeter lesions, it did very good with 80% 1 year primary patency. And this is the other study of Lutonix, the other drug coated balloon from BART, which is presented at Viva again last year. It is not peer reviewed, not published. It is a prospective global multi-center single arm registry. This is from Europe, involving 10 countries, 38 centers, 691 patients. The mean lesion length was 101 millimeters, and 20% were really long lesions, more than 140 to 500 millimeters. And in this study they had a 12-month outcome. In the long lesion subgroup, the mean length was 212 millimeters, and the freedom from TLR is close to 93.7%. What about a combination of directional atherectomy and DCB? And this study has been published. It's called Definitive AR, and this is a study where the directional atherectomy and then DCB was compared to DCB alone. As you see, this study is thought provoking. In a subgroup of lesions where the lesion's length is more than 10 centimeters, DCB did very well with 85% 12-month patency, but the important thing is when the directional atherectomy is added to the DCB, it did extremely well with a 96.8% patency. But this is a single center observation. This needs more data to support this, but this is thought provoking. I just want to end the presentation with the economic analysis comparing different endovascular intervention we have in femoropopliteal lesions. So this is again presented in Viva 2015. It's not peer-reviewed and not published. It compared all the different modalities we have at this point of time: PTAs, BMS, drug-eluting stents, drug-coated balloons, and the Supera nitinol intravenous stent. And what is the cost from the perspectives of US payer, Medicare, and hospital? TLR was defined. A decision analytic model was developed to estimate the cost associated with each strategy, and risk of TLR was used to derive the expected number of re-interventions for each strategy over 3 years. It's very thought-provoking. The economic impact was determined, and also economic impact to the hospitals, to the payers, and everything was defined. So the results of the economic analysis, I don't have the numbers, it's not published, but the author presented that from the patient perspective, the intraoven nitinol stent was associated with the lowest risk of repeat procedures. From the payer perspective, the intraoven nitinol stent was more effective and provided cost savings compared to PTA, BMS, DES, and DCB. And from the hospital perspective, the intraoven nitinol stent resulted in the greatest remaining payment per procedure compared to PTA, BMS, DES, and DCB. But this is the old data. The newer data coming from DCBs are also promising, but at this point this is what I have, and I end my presentation here. Thank you very much. PK, back to you.
Got to come back into the room, guys. You can't show that. Yeah. So let me show you what we've done in the meantime before we start discussing what Sachin talked about so nicely. Two things. Sorry. I got to go the other way. So two things. So what we did in the meantime, like we talked about, we went ahead and we angiojetted. So we got the filter down, and then we angiojetted all the way down, the proximal, and then the mid distal, as I said. So there's the mid distal, and we angiojetted up and down. Once we angiojetted up and down, I want you to look at what our result was, and now you can see you have flow in that segment that I told you about with a little bit of, again, very, very chronic disease distally. So now you've actually have uncovered the pathology that's lying inside this, and now we can come to our discussion that we've been having, right? So the discussion we've been having is very simple, Vishal. The question becomes is, well, based on the current data, okay, there's no randomized controlled trials comparing products, how do you make a decision in your practice on how to treat these patients? And I think that's the discussion we should have before I quickly take care of this case.
I mean, this is a very, the data presented by Sachin.
I can't hear you.
Can you hear me now?
Now I can hear you.
Okay, sorry. The data presented by Sachin is pretty impressive. I mean, keeping in mind all modalities we have, like DCB, Supera, DES, and with the patency running anywhere between 79.3% all the way to 93%, is very encouraging, especially for patients like these who have claudication. So I think it all depends on how much calcium. For me personally, it all depends, if I have all the tools, of course, in my lab, how much calcification there is, how tough or calcified the lesion was. In your case, it was both a combination of thrombosis and calcification. So for me, if it's a very calcified lesion, I lean towards first, of course, doing atherectomy and then seeing the result. If the atherectomy results is very satisfying with minimal or non-flow limiting dissection, then I could go either DCB or Supera. But if there are focal areas which are very calcified, unyielding to non-compliant balloon and atherectomy, then I lean towards try to do focal stenting of the calcified lesion, and rest all we could do DCBs. Of course, you can argue one way or the other, doing Supera stenting, how comfortable you are, and the calcification, but it's merely based on how the lesion behaves, especially. I mean, my to-go is atherectomy followed by the decision making. How would you?
I think those are great points, but I think if you want to break it down for the people at home watching, I think we have to break it down in this manner. First and foremost is, if you look at all the studies, we both have said it, and Dr. Jain has said it as well, there is no randomized controlled trial comparing one product to the other. So that's out the window. So we don't have level 1 data to say, with this or the other. But as clinical practitioners, we have to evaluate the data and apply it to our patients in the best way that we possibly can. There are going to be plenty of room for disagreement, and personal preference, but I think we need to start talking. So let's take this particular patient. So you have a patient with a long lesion, probably greater than 200, right?
Right.
In the entire involved cohort. Second, you have a degree of calcification. Third, what is it called? You have a runoff of, say, one vessel, if I remember properly. So if you just take the patency data out there, and if you look at lesions that have been studied in this particular lesion length, you're probably looking at the DCB, okay, with the impact data, global data,
Right.
looking at lesions of 25 and greater than 25 centimeters. Remember, their provisional stent rate in that particular cohort was around 40%. And they also have published their registry data, or not published, presented their registry data, yet to be peer reviewed, showing that it has a very, very acceptable patency when the lesion is less than 25 and probably acceptable when it's greater than 25. So that's one. So DCB with or without stenting is an option. Second, if you look at the Cook Silver PTX Japanese real-world registry, all comers, you have an average lesion length around 14.9 centimeters. So again, it's a little shorter lesion length than what we have here, but the fracture rates are only 1.9% in the IDE trial, and don't go above 1.9% in 3 years. So therefore, again, now you've got another option to say, hey, if I need to stent, I have the Cook Silver stent. Third, you have the Supera 500. I don't remember the average lesion length in Supera 500. Do you remember?
It's like
What
20.
was it? 14. So
14.
Supera 500 average lesion length was around 14. So again, it's not quite as long as what we're discussing, but clearly there were lesions that were longer than this that were involved in that. So Supera could be another option. But remember, in today's world of DCB, DES, or covered stent technology, or leave nothing behind, you need to start looking at it. And the sparsity of data here really lies in atherectomy. There is really no long segment atherectomy data that's available to us in looking at lesions of 25 centimeters in a large patient cohort. I know Zeller's reported a lot of stuff out of smaller patient cohorts and out of single center experiences. We don't have multi-center even registries to talk about with this. We don't have that with the Jetstream atherectomy either. We know that the different Jetstream atherectomy IDE studies, all of them included only short lesions in their studies. So here I believe that atherectomy becomes an adjunct to our therapy. So I think that atherectomy has to work here for whatever reason, either a high plaque burden, either you have a heavy calcium that you feel is non-expandable, or whatever your preference may be for you to use it. That's the reason to use atherectomy. If you said to me, hey, all I'm going to do is do a balloon angioplasty and a Supera stent, it's probably fine. If you told me I want to do a DCB and a short focal stenting, probably fine. If you told me you want to do a Viabon, you saw the trial there.
Right.
You have out to 25 centimeter lesions studied with Viabon, both in the ISR cohort as well as in the long lesion cohort, with a 75% primary patency rate, probably fine. You might have your biases saying that, oh, it's single vessel runoff, but if you look at the trial, these things don't go down hard. Whatever said and done, those acute limb situations that all of us worry about has not happened in the randomized controlled trial in any significant manner. So therefore, you could say that in the Viabon studies, that's because of great follow-up, but you don't know. You don't know. So I think at this stage, that is also a viable option. But I think it's important for the audience out there to sit down and analyze what it is that they're going to do by using the current data that's available. So in this case, what are we going to do? Well, we felt there was thrombus, so we put a filter down. Okay, we did angiojet. I've demonstrated with angiojet alone, you've got a lumen. So clearly there was thrombus in this vessel. So if you're doing these kind of cases and you don't recognize the underlying pathology, you might have showered embolus all the way down distal to taken a claudican and made him into a critical limb ischemia. That's number one. Number two, now you and I both agree that there's a significant amount of calcium here. So I'm going to have Dr. Jain go ahead and start atherectomy. And what the atherectomy device that we're going to use is the Silverhawk atherectomy device, just because in our hands we get the best results in it. Yesterday at Link, we did a case with Pathway Medical, and with a heavily calcified lesion. Worked out just fine, So you could use any particular case or a lesion that you want or device that you want to treat. Once we do the atherectomy of this, we're going to take a picture. We're going to take a picture to see three things. One, is there any flow limiting dissections? Two, what is our luminal gain? I mean, are we getting an adequate lumen here with atherectomy to really look convince us that we can likely expand this lesion with just a regular balloon? If we need to do a high pressure balloon angioplasty, that will also let us know if this has not expanded properly. Once we accomplish all that and we have good lumen and flow, then the decision is going to come to, well, are we going to do a DCB? Are we going to do a Supera? Are we going to do a Viabond stent? Now, the technique of atherectomy is important. As you can see, they've chosen a very long atherectomy device here. Is it crossing that or no? Push the filter slowly. There's nothing in the filter. More. Now, don't try this technique at home. You don't want to do that. But, I mean, this is something we use a lot of product, a lot of different cases, and a lot of different products here. So we're pretty experienced, so we can show you that that can be pushed. Now, that filter can be pushed while the other filter from Medtronic cannot, because it's obviously attached to the wire. So this one is independent of the wire, so if you push it along with the wire, it will go forward. So now we're going to do the atherectomy, and Sachin is going to do a 4-quadrant cut here. Where's my sheath, guys, up top? Always remember that the sheath needs to be somewhere in the picture. Where? I don't see it.
It's pictured right in the distance.
Okay, great. So now we're going to go ahead and do the atherectomy. So I think that's the thing, Vishal. I'm sorry to be so long-winded.
No, that's good. So there's a question that just came up asking about when do you get the CTO devices into play? Like, do you bring it up front? Do you bring it at the last salvage? Like, what's your normal protocol or algorithm you get these CTO devices?
I think if you look at the cost analysis, and I know that there's a paper that's going to be, at least I know Dr. Banerjee was working on this data. I don't know if he's published it or not. There's a paper that's coming out in JACC or whatever it may be about the cost analysis. I know that he's working on this. He basically is trying to analyze what it costs to do these procedures. So in our opinion, these devices are extremely costly and really have a role in difficult lesions. So if you feel that, hey, you know, I can't get through, I'm not able to get through, then I think they play a role. For us, our threshold for bringing these devices is very, very high, in the sense that we use it only when we feel that a standard wire technique may not work. So we are asking a lot of these devices by putting them in the toughest cases, but in fairness, you're paying a premium for these devices, so they should work in the toughest cases. That's my opinion. So to answer your question, our CTO device use is quite low, but we use it only when we think it's necessary and when we can't get through with standard techniques.
So, I mean, one more thing. What about the use of filter? I mean, do you use it based on your distal vessel runoff, or a combination of both thrombus? I mean, in this case, of course, thrombus is playing a part. But suppose there was no thrombus and was all calcified. When do you get the filter into the play? Like,
well, Vishal, I know I haven't told you about this yet, but we're looking at our filter use here at Sinai. We've taken 500 consecutive filters done over the last, I think, 2 or 3 years, whatever we've looked at. And we were looking at what our filter capture rate has been, and what meaning the macroscopic embolic rate, as well as we're looking at where the filter really captured things. I can tell you by my experience, which again is anecdotal, but however I believe in it, and it's done us justice in the past, is that I think there's a role for filter in certain types of lesions. I think number one, in all calcific lesions, when you're doing atherectomy, you should use a filter despite whatever device that you decide to do. I'm being honest with you. Mm-hmm. You were there obviously in our case at Link yesterday, you saw the amount of debris that we had in that filter, really saved the day. Number two, any long segment atherectomy, such as anything above, say, 150, I'm going to throw out an arbitrary number, where you have a heavy plaque burden with single vessel runoff, I think you should use a filter. Number three, what is it called? When you're doing in-stent restenosis, regardless of the device you decide to use, you should use a filter. Because I think that in-stent restenosis has a lot of thrombus that's involved that people don't realize. And also, if you're using certain devices, you can macroscopically embolize these things, these debris. Number four is going to be anywhere where you suspect thrombus. Whether you have a case like ours where the thrombus is really highly suspected, or maybe where you feel there are areas where you get through an occlusion, which is very difficult, and then as you push through, suddenly it becomes very easy, and then you hit another occlusion. So what's probably happened there is you've got an area of stenosis and occlusion, a hibernating section probably fed by a collateral with clot, and then another area which is hibernating, another area which is now occluded, and then a patent area. So that segment in the middle is where you're going to have your thrombus. And once you get through, you balloon it, and everything goes downstream, and now you're in a 4.5-hour case. So our filter use is judicious, but I think it is not small because of the fact that we're very, very aware of where we think the filter needs to be used. So here, as you can see, Dr. Jain is doing 2-quadrant, 3-quadrant, I think he's in his 3rd quadrant atherectomy. Since it was a pretty totally occluded vessel, we're probably just going to do 3-quadrant atherectomy here. He's trying not to gutter back into the quadrants. And I get this question a lot. So, and I got to be honest with you, this is a very valid question. They're like, Prakash, your group published the data on adventitial injury with Silverhawk, and yet you continue to use Silverhawk. Well, the bottom line is, to me, it's a tool. I really believe that yes, you cannot predict where the adventitial injury is occurring with Silverhawk, but I think if you try your best to really prevent the guttering, you're going to reduce that. However, you still can't predict, so you might need to do intravascular ultrasound or DCB. If you're going to DCB this entire segment, there's no need for intravascular ultrasound. If you're going to leave it with standalone Silverhawk, then I think you should do intravascular ultrasound to ensure that you don't have adventitial or medial disruption in order to be able to reduce your restenosis rates. So I think that was a very valid question that I had by somebody. We've also submitted another paper recently with looking at the utility of IVUS, and we're waiting to hear back in identifying these cuts. Hopefully that will also get into one of the journals, so this way we can also add to the literature on that. But I really believe that in these long segment lesions, adjunctive therapy, especially with calcium or just heavy plaque burden, is going to make a big difference. Guys, watch the distal wire because he has occluded vessels below. So now you can see with this wire, you can see it's free moving. So you really have to watch the distal wire with this Abbott filter. Now we're walking it out, and now we're going to do a DSA picture, guys. So our goal is to get this done in an hour. It's right now 8:45, right. So we've got 15 minutes to do our final work. And you can see a lot of things have been covered by us. And this is the thing. So let's do a quick picture. Okay, you need to show this one over here. Okay, let us see.
Very nice.
So you see that, Vishal? Now
yes.
we've got a nice, I'd say a very nice thing. So, right now at this stage, I want to check my filter. And this is another thing I always teach or preach to all of you guys, is that this filter has to be checked frequently, because especially when you do aggressive debulking, you are going to embolize. And hopefully we didn't embolize, because it's going to make for a longer case. And we didn't embolize, thank God.
Yeah, I guess you're right. I mean, this is one of the tricky points that can get you into real trouble, is if you underestimate the complexity of the filter and the distal embolization.
In-house then, it doesn't matter. So in this case, I think now, as you see by the picture, I'm going to go scene minus here. As you can see, Elizabeth does a wonderful job of sedating, and that's why our patient is resting comfortably. And I just want to show you the picture, and then we can discuss what our plan is. So you can see our picture here now shows a lesion that's been debulked with areas really of some dissection, but
right.
nothing horrible.
Exactly.
And I think this is a credit to recognizing the thrombus, and also recognizing use of an 014 wire over an 035 wire. Rather than an 035 wire. So now we have decided to follow the Impact Global data, or you could follow the Lutonix data. What are we using, guys? You want to use Lutonix or Impact? What do you want to use? Oh, they already opened the Impact. So we generally could use both. Advantage of the Lutonix in this particular case is it comes in 150 millimeter, but Sachin is a stockholder in Medtronic, so he feels using more.
The fellow needs to earn some money.
I'm joking. I don't want anybody to get upset with this. Is just to say that he wanted to use an extra balloon in this case. But the point is, with the Lutonix balloon, because of the sizing, and I know that the Medtronic folk are working on longer sizes, we will be able to use one less balloon at today's day and age if you wanted to.
Right.
I wanted to ask your opinion on the two trials. I get a lot of questions, and I'm sure the audience is also thinking, is it a class effect? Is one balloon better than the other? I'm just wondering on what your thoughts are.
Well, I mean, it's really hard to say. I mean, if you really go down to the tethers of it, one balloon has based purely on the concentration. One is 2 micrograms per ml, the other one is a 3 microgram per ml balloon. So could you say that 1 microgram is going to make a difference? It's hard to say. Again, you have to go on to the microbiology and all that stuff for it. But the pathology of it. But I mean, for me, it really, personally, on a clinical basis, especially following up these patients with serial ultrasounds, I haven't seen a big difference between using one category of balloon, whether it be Lutonix versus the other one on a head-to-head. Unless there is a head-to-head trial, I think it's just a class effect that comes into play.
So I think that that's a good point. I always get into this with people. It's very hard to compare trials, as we just spoke about. You know, endpoints are different. Meaning in the sense, what is a PSVR in the Lutonix trial is 2.5. What is it in the Medtronic trial is 2.4. So the endpoint may be different. Number two is, in terms of blinding, there is issues with blinding. People say one trial was blinded over the other. I don't look at it that way. I look at it as in this particular category, drug-coated balloons work. Okay, whether it's a Lutonix or a Medtronic balloon, or Impact or what is the other one called?
Lutonix.
Lutonix. So sorry, it's a BART balloon. Lutonix balloon. I think it doesn't really matter. So I really believe that if you're going to use it, you need to use it for whatever, either one works fine. Until we have head-to-head trials, we won't know which one is truly better than the other. Number one. Mm-hmm. Number two is, as far as drug-coated stents are concerned, that Boston Scientific is doing the Imperial trial. So the Imperial trial is actually the first trial in the peripheral space that I congratulate them wholeheartedly, because they've actually taken the premise that their stent, the Illuvia stent, which is not yet FDA approved, is better than the FDA approved Cook Silver stent. But at least we're going to get an answer. Then you and I can now say, hey, this is not inferior, it's equal, there's no difference, Illuvia is better, or Silver is better. So I think that's what's going to need to be done. Whether Medtronic or Lutonix chooses to do it, we don't know. But I think this is something that's going to need to be done either in a single center fashion, multi-center fashion, to really add to our data. So I think at this stage, I agree with you that in terms of our use, if we're going to use a drug-coated balloon, I would have probably used the Lutonix balloon here because I have 150 length, but Sachin obviously made his decision based on great data. So I don't think anything is right or wrong in this situation.
Let me add, there's also one more thing. Remember at Viva, there was a talk about preparing the lesion before we go to the DCB. What's your thought process on, how we prepare a lesion when we put a stent in, more so in the coronary and the peripheral? But in your case, do you prepare the lesion with a PT or a plain balloon angioplasty before you deploy the DCB? Does it change the absorption of the drug if it's better prepared with the pre-dilatation, or just directly go for DCB? What's your thought on that?
I think that's a great question, and I always look to our European colleagues to get an answer here because they've had more than 5 years ahead of us with the use of DCB. Down, guys, that's fine, down. So 5 years ahead of us with the DCB. So you could see that in Europe, they generally do not pre-dilate to the use of the DCB. If you look at the IDE trial with the Impact SFA, the European arm did not mandate a pre-dilatation. The American arm did mandate a pre-dilatation. So therefore, I think the jury's out. I think in America, we generally tend to pre-dilate. We chose not to pre-dilate here because we had already done atherectomy. We had a very good lumen. We could have pre-diled, but we didn't. So I don't think we're wrong, and I think we have a lot of support with a lot of colleagues of ours who have used this balloon to be able to tell you. The second thing is to avoid the geographic miss. So I hope Sachin and Ray, because I know they're both good operators, know where that balloon landed, because I've been talking to you guys. I can tell you, see that picture right there? That picture is very important. Every time you balloon a DCB, it's important to take a picture, and you need to have the glow tape. Our tech, our world-class tech, Ricardo, always puts a glow tape on for us to be able to see exactly where that particular balloon ends. So you don't want to have a gap between the two balloons. Matter of fact, the trial has clearly said that you want to have that 1 millimeter overlap. So now we're going to do another balloon here, and this is kind of like watching paint dry, which is kind of boring, but what are you going to do, right? We're going to have to do this. But right now we're going to open another 120 balloon, and then probably another 120 balloon, and then we're going to take a look. We are going to end at 9. I don't want to prolong it, but what I do want to tell you is that our plan here will be to spot stent if we see a dissection. And I think we'll be able to go maybe 5 minutes over to
Right.
be able to show you what we end up doing, because I think seeing the final result is very important. So you know, as far as vessel prep, other than that, I don't think there's any data that supports that. Like, I'll be honest with you. If you look at the IMPACT Global 150 patient cohort for long lesions, you had a 40% stent rate, which as compared to 6 or 8% in the IDE trial. If you think about it that way, you know, and the differences between the stent and non-stented arm were rudimentary. So I don't know whether this is saying that we don't need to do atherectomy in other than very heavily calcified lesions, because obviously these long lesions were also heavily calcified. If you looked at the calcium content of these long lesions, what was it, 30% or 40%
Yeah.
or 60%? I can't remember. I don't have the slide in front of me. But it was also a very, very high number of heavily calcified lesions. So you start to wonder, well, what is going to be the role of atherectomy in these particular lesions? And I think we're going to find that out, because I know that I think the Viva group is planning on doing a trial on that, which is going to give us a lot of help in answering this question. So I believe that the data is growing and it's going to help us. But I think in today's day and age, this case demonstrates what the available data is and how we make those decisions. I know that yesterday, Vishal, you remember, we were talking with Europe, and especially Andrew Holden and all the guys in Europe when we did our pathway case.
Right.
They felt that the absorption with calcium will be limited. You know, we didn't have time because it was a 20-minute session. Like, this is an hour-long session to sit and discuss what are the different options. However, you know, if you look at that, it would be interesting to ask, you know, the European guys that the IMPACT trial did show in these longer lesion cohorts that these patients did well at out to a year so far. So I'm just wondering whether that calcium is a barrier, but probably not as much a barrier as we think it is. I think also in our symposium now, we're hopeful to invite one of the world famous pathologists, hopefully Raina Vermani, if she's available, to come and talk about the pathology of DCB balloons. So I welcome the audience to come to our symposium, because we're going to have Dr. Scheinert and Dr. Schmidt sending two live cases from Germany. We're going to have exemplary cases with DCB, and as well as with other different technologies, really highlighting all these things that we're talking during this particular session.
Oh, great.
So right now, what Dr. Jain is doing is looking at the ostium
Ostium.
to see where he should end the balloon, and I think he's going to end it just shy of the ostium. And you know, the problem with the DCB is it's painful, like the lady's having pain, but you do have to have a minimum of a 3-minute inflation. So you know, it's where you need really good nursing, like Elizabeth, and just basically, you know, letting the patient, you know, giving her meds and letting her be calm. Another 60. Ricky, and a 680 balloon, Ricky.
Oh, yeah.
Lo siento, mama. Lo siento, mama. Uno ves. Okay. So, yeah, it's very painful.
Well, that's the wait and watch with the DCB.
I know, that's the problem.
So once you've done a DCB, and suppose you find a flow limiting lesion, or you're not happy with the end result, for spot stenting, where do we stand next? Do you go for a bare metal stent? Do you go for a drug-eluting stent, or you go for a Supera? Because you've already done the atherectomy, so we are hoping that the calcium part is at least shaved off or a little bit taken care of. So what's your strategy on what kind of stent would you end up using? And what's the benefit, if there's any benefit of one over the other? I don't think there's data, but if you probably have something to tell us.
You know, that's a great question. I think once you've used a drug-coated balloon, there is no reason to use a drug-coated stent. I think the consensus among operators and people who have done a lot of these cases will agree with that. I think but the important thing to understand is that I think a bare metal spot stent was good, and obviously at today's day and age, I mean, a lot of people may end or edge towards Supera just because of the data that Dirk and Andre have presented. So I think that Supera obviously has a lesion, has a role in these lesions, but so does regular bare metal stenting. Let's take a look. She's having a lot of pain. We're just going to take a look. Is she okay? Okay, give her a little dye. Just a little dye. Inject. Okay, so it's obviously, there is an area of hyperlucency, but you could see that everything is good. The filter is migrated up, which obviously you don't want, but that's okay. So now we're just going to do one more DCB proximally.
So you could go over, if you have to, one stent over the other. You don't have any personal preference.
I honestly, I think that, in my opinion, I think so you should use a Supera. I think other than the ostium, I think you should use a Supera.
Yeah.
At the ostium, I think you can use any stent that you want. So I think that's our preference. So at this stage, you saw there was a little bit of a hyperlucency telling you that you're going to have to stent. There's a lot of recoil. Lidocaine, guys, in the groin. Let me just. ¿A dónde dolor, mamá? ¿Aquí? ¿O aquí? Oh, lo siento,
So
lo siento.
just in the meantime, to just update our viewers, our next live case is scheduled for February 24th at 8 o'clock Eastern Standard Time from New York. Of course, you can log. This case will be present on archive by the end of the week on peripheral.interventions.org. And our CCVVC symposium is going to be held this year between June 14th and 16th in New York City. Kindly stop by at our website, cccsymposium.org, to register and for more details.
Yep.
And we look forward to seeing you at our annual symposium.
Let me come back
And again, to repeat, our next case is February 24th, 2016.
So I got to tell you, whether Vishal, whether you can talk a little bit about the fellows course, what you're planning.
Right.
You're the director of the fellows course with Dr. Guja. So I'm wondering whether you could just talk a little bit about that.
Just to add on to that, thank you, PK. So our main focus, especially for me and Dr. Guja, is to get the fellows updated and up speed to the present technology and the use. So we have a very well-defined day, which is a fellows course, which happens one day before. And in that day, we'll have structured lectures. And in between them, there will be, every session would have question and answer sessions, 5 to 10 minutes after every session. And then we'll have breakout sessions where we'll have one-to-one discussion with these world-renowned faculties who come in, where you can have case presentations. You can get your cases. We'll be more than happy to discuss. Otherwise, we'll have some cases of our own to talk over and get their personal opinion on how they would do their own cases. And at the end of the day, the most exciting part is we're going to have a cadaver lab where you can actually go in. There's a cadaver, deploy stents, balloons, atherectomy, all the various devices, pretty much like a virtual live symposium. So I think that will give every fellow an opportunity to really see and feel how a device, if they've never worked on it, how it works in the body, how the body responds, the vessel and everything. So I think that's one of the newer features we've added this year, and we are very excited about it. And hopefully, once you join us, you'll be more than happy and satisfied with the cadaver symposium we have at the end of the day. So it's a very structured, not overburdened, overloading session. It's not, there are talks for your education, but there's a lot of personal one-to-one interaction with these faculties, and then of course the devices and all the rest techniques, especially to make you skilled when you go out as an attending. So at least you'll have the knowledge and the experience with various devices present. You might use one over the other based on personal preference or hospital preference, but we give an opportunity for everyone to see everything at the same place at the same time. So we would love, again, for you to come to our fellows course, especially the fellows who are watching, and the faculties, if they can excuse their fellow for a day or two. Enjoy New York City, and then of course do the learning.
Okay, so we've now done the DCB. We're going to walk it out. We're going to take a picture, and I'm going to let you know what we're going to do. And we will. She's having obviously a lot of discomfort with the balloon. It's a very calcific lesion, so therefore, as you can see, the filter has moved a little bit, but not horribly. But we will go ahead and take this balloon out of her, take a quick picture, and then decide what we're going to do. Muy bien. Okay. Okay, mama. Okay.
I think it's just a sedation probably wearing off as
well. Well, we give her some extra too here. So you can see that mid segment
Yes.
with the thing is going to be the issue. So we're going to go ahead and put a Supera. Can you give me a filter capture? Can you give me a Vertip catheter? I'll capture this filter and put a wire down. So we're going to capture this filter. We're going to put a wire down, and we're just going to put a Supera in the distal, and then we're going to evaluate the ostium and decide what we're going to do with the ostium. But at this stage, I think that what we'll do is we'll probably put a Supera in the mid-distal segment, and then we'll decide what to do with the ostium.
I think that's a good idea. I think that's where our wire was deviating off anyways. It was unyielding, so that's where.
What's the matter now? You want to give us some? What about?
I think it's very important for the viewers to always make sure and take regular pictures, especially when the patient is complaining of pain, just to rule out any perforation that might be adding on to the whole clinical scenario. That's why you'll see PK take these pictures, especially after ballooning, after atherectomy, just to make sure, especially when the patient is complaining as well. I think that's an important point to consider while doing this procedures.
So here we're just gonna, we're not gonna be able to take it out as one. I wanted to be able to switch out the wire, but it didn't fit. So what we're gonna do now is we're gonna put a Spartacore wire down, and then we're gonna quickly put a Supera. And then once we deploy that Supera, we're probably gonna go ahead and say goodbye. I think by showing you a final shot, and unless the ostium needs something to be done. I can tell you that this just becomes standard stenting. So I mean, I don't think it's as big an issue to watch, since most of you obviously know how to deploy a Supera.
So what size Supera are you going for?
We balloon with a 5, so we're probably gonna 6. I mean, we're probably gonna go with a 5.5 Supera. Show me above.
So I think for the viewers, it's very important,
Above.
especially in Supera, to balloon dilate or pre-dilate before deploying a Supera, and keep the balloon 0.5 millimeter above the size. So like PK said, if you're using a 6.0 balloon, then a 5.5 Supera, and accordingly. And of course, we have to vessel size it anyways. But
let's take a look. So here now we're going to evaluate the size. Give me the DSA, guys. So now we're going to evaluate the size. Obviously, she's a little bit more sedated. You want to give her some H? Okay. So it's really just, honestly, you know,
Very
with the
focal.
DCB, it's a focal Supera, but I want to look above this just to see what's going on here. You could argue to leave it, man, but I don't know. I mean, that one area is pretty nasty.
I don't like, yeah, exactly.
That one area, you can even put a shorter stent, but let me just see the ostium as well here. Mag up. And I think this is another important question, Vishal. This is what we don't know. We don't know which of these lesions should be stented with a DCB. You see that? Now, that's also pretty nasty. So does that need to be stented as well? So in likelihood right now, we're going to go distal, place a short Supera. What's the shortest Supera we have, guys? Yeah.
5.5.
80 is the shortest? You don't have a 60? So roadmap here. Oops, she moved. So I think what we're going to do is we're going to
Focal stented.
What's the matter? What's the matter now? Having cramp? Mehar? I think it's just a cramp.
Yeah, I think so.
Okay, Mehar? Okay. Okay. So Vishal, I think let me take a final shot here, since the patient is having issues with sedation.
Sure.
What we'll do is we'll show you what it is now, and then next month we'll show you our final result to let you know how it did turn out. I want to show you that we've now opened the SFA. Okay, we're going to stent that mid lesion there, and likely the ostium. Likely, I'm not certain. I may do a prolonged balloon, see how that turns out. I want to show you the distal runoff. Okay. She's cramping, that's all. She's cramping. Okay. You can see that the distal runoff is still preserved. She's moving, but you can see there's a vessel.
Oh, it's a beautiful
and it's all the
inline
way
flow.
down. So at this stage, what we'll do is I'm going to sign off while Sachin decides what he's going to do, and I just want to do a quick overview. So I think this case has a lot of merits that we talked about. So first and foremost, you know, we looked at a long segment CTO in today's day and age. Please, she's cramping, guys. A long segment CTO in today's day and age. So if you look at today's day and age in terms of how we handle these difficult to treat lesions, I think it's important to correlate the data along with the anatomic presentation of the disease. So the anatomic presentation of the disease in this particular case was a calcified SFA with thrombus. So therefore, I think first and foremost is recognition of the thrombus. If you recognize the thrombus, then you need to take steps such as using the filter and using the thrombectomy device in order to go and treat that, to tackle the thrombus. After which, we talked about the different data that are available. Okay, the different data that are available clearly show there's a multitude of data that's available to treat these lesions. However, what data fits the patient that you are currently treating? So we went over the data with the Viabond, the long segment, the DCB real world, with atherectomy, with Cook-Zilver PTX, as well as with the Supera. So in this particular case, we used a Silverhawk atherectomy to debulk the lesion and DCB, and we're going to focal stent. I think in today's day and age, with all the available data, it's important to do this in this methodical, thought-out manner. I appreciate you joining me. I apologize for the patient. Obviously, you're having some pain, which is very understandable, and we will go take care of that. So I'm going to sign off and show you the results during the next case. Thank you again.
Thank you, PK. A very excellent case and a very elegantly put in data to the clinical presentation. Thank you, everyone, for joining us this Wednesday morning and taking time out to view our case. For those who missed the case, again, we'll be in the archive section by the end of the week. Please do join us next month, February 24th at 8 o'clock Eastern Standard Time for another exciting case from PK and his team at Mount Sinai Medical Center. Till then, have a great week.